it is always good to have the most fun topic, I think, in a presentation like this. So, in that vein, George Bernard Shaw, the playwright and satirist, did remind us that life does not cease to be funny when people die, any more than it ceases to be serious when we laugh. So I'm hoping that you'll enjoy this presentation and not so much see the funny side of it, but don't feel bad about enjoying thinking and thinking about something that's going to happen to all of us. So here we know that if we say, well, who dies? Well, we all do. In fact, if I was to do a count, as I do in class sometimes, I'll say, okay, you know, the death rate for heart disease is 50%. So if I call you off 1, 2, 1, 2, 1, 2, okay, all the ones, you just died of heart disease. And so you can do, but if I do the death rate, of course, it's 1, 1, 1, 1, 1, 1, 1. The thing about dying is, though, that 90% of all the deaths that occur can be anticipated. They're usually due to chronic or known disease, and they happen to people who are in contact with healthcare professionals. So you would think that we wouldn't be surprised when people die, but surprised we often are. If we look now at what causes death, what do we die of in the United States? I've given the first one away anyway. You know, most people, or a lot of people die of heart disease, followed by cancer. A lot of these other diseases, which seem not to be such a big cause of death, of course, they are often cumulative and people have more than one. So, and over here we have all the rest accumulated together. So my suggestion to you is avoid heart disease, avoid cancer, and avoid all other. So who dies and when do we die is the next question. As you can see, we're very, very fortunate in Western industrial countries, including the United States, that the death rate in infants under 1 year is quite small. It gets even less as you go through childhood. Despite what your mother says about taking care, it's actually much safer then. And as you go through life, when you get hit a retirement, actually start to see the numbers jump up. Of course, one solution to that might be don't retire, but I don't know that that's a very good solution. So, as you can see, most people die in the 85+ year range. Where do we die? Well, if you ask people, and many researchers have asked this question, people will say that they want to die at home. They want to be in their own bed, they want to be surrounded by their own things and the people who love and care about them. Unfortunately, about 2/3 of us will actually die in an institution, either a hospital or a nursing home. Almost 1/4 of us die at home, which is good, and a very, very small proportion of people will die in an inpatient hospice. The interesting thing about that is that if you ask people their second choice, it is an inpatient hospice. And as you can see, you've got a very small chance of achieving your second choice. And if you're very old and you don't have cancer, then you have virtually 0 chance of dying in an inpatient hospice. So what is dying? Now that is an interesting question. I'm going to talk about it in terms of processes. The first is a physiological process, which sort of makes sense. And the dying process is triggered by advanced disease, by aging, or by trauma. And it would be defined as the irreversible shutting down of bodily functions. Now, this process of shutting down is quite interesting, and it would be the topic of a whole other talk. But in actual fact, we can see that what's interesting about it is that the signs and symptoms of dying are actually the signs and symptoms of the body trying to survive, trying to stay alive, trying to keep the vital organs, and particularly the brain, alive. So even the dying process is about survival. What's it like? That's really hard to say. It's hard to tell you what it's like when you haven't experienced it. But when I teach in this area, we usually look at the near-death experiences type literature and people's stories of those things to try and understand what it's like. And suffice to say on this occasion that it's not necessarily a bad experience for the person who's dying as it's actually happening. So without being too trite, I've also added that the physiological process of dying happens just to the dying person. whereas the psychological and social processes actually apply to the dying person and to those around them. So these processes are called loss, grief and bereavement, and they're quite familiar to all of us, I'm sure. The third process is that it's transitional, affecting all of us. Now, we actually go through lots of transitions in life, lots of developmental transitions, and I've listed some of them here. Going from being a fetus to an infant is a transition. The process is birth. Being a child, becoming an adult, the process is puberty, and we give it a special name of adolescence. And you can see, even social transitions, we have special processes to go through to help us with that transition. Being alive to being dead is also a transition, and the process is dying. Being a couple to becoming single, the process is grieving, and that is whether it's a socially constructed separation or divorce, or in fact due to death. So, what does it look like? Well, all of these transitions actually we know very well. We can see them, we can understand them. We look at pictures as I've got here showing a parent looking at a child, their infant, and what you're actually looking at is oxytocin. Now, mostly we look at a loving picture between a parent and child, and we don't think about whether we need to take blood tests to see if we can see that bonding. But that's what's happening. And so we can see the survival process at work right here, because without that oxytocin, it's very difficult to take responsibility for something which is basically can't do anything, is very dependent, can't even run away from danger, and so we are required to look after them. Same with adolescence, going from childhood into adulthood. We know that process. We don't think, oh, look at that messy teenager or grumpy teenager and think, well, what's the estrogen and testosterone doing today? We don't think, but there is a biochemistry, there's a physiological process, and we're very, very familiar with it. And the same with falling in love. So each of these transitions as we go through life have this process going on, these processes going on, and I'd like to think that dying was the same. So my first proposition to you here is that transitions between all developmental stages in the life cycle must have recognizable biochemical or physiological as well as socially constructed components, and that the combined effect results in promotion of survival. So what's the problem? Well, we think that we can't see dying, and we have a lot of trouble recognizing it as a developmental transition. We don't understand how important it is to do this developmental transition as well as we try to do the other ones. And when I talk about dying well here, I'm really talking about being healthy about what we're doing. We look at the birthing process and trying to do that in the most healthy way. And adolescence, we look at that as being hoping for healthy transition, because that's all important to the ability to survive and to pass on your genetic material eventually. And as far as survival then with dying, the point is that dying well helps our families to grieve, our families being our genetic material perhaps, and then going on to continue with healthy lives. So can we see dying? Can we understand what it looks like? We don't need, just with all the other developmental transitions, we don't need to take blood tests. We don't need to do any more than observe and understand and be aware and become familiar with the process so that we understand when it's happening. I've spent quite a lot of my research career trying to understand this problem of when is it happening? When is it happening so that we can transition to better care? And if you are interested, this is one of the ways we did it, which is a quantitative, highly quantitative way of doing it for nursing home residents. And if you want to follow up on more on that, you can check it out at this website, where you can go in and use any of these calculators and see when maybe someone you know might be at risk of what the index is for them for dying. If you have a large inheritance, that might be worthwhile. It's not just enough to go along and say, oh, this number, you know, this is your predicted amount of time that you have left. It's an extremely complex area of life and of healthcare. So what we did after we found that we had a scarily accurate prognostic tool is we went back into the nursing homes where we developed this and asked the people who gave care directly to residents in nursing homes, how did they know that somebody was dying? And this was the results of the first study. And as you can see, perhaps, that there are ambiguous cues, decision cues, these cues or triggers, which in a linear process started to make the care workers, so certified nursing assistants, registered nurses, etc., who were looking after these people, they led them to realize that death was coming closer. And this was happening over a period of months. And so I called that process increasing death awareness. What was also interesting is that they had, in order to get to end-of-life care and actually transitioning to appropriate care at the end of life, they also had to overcome their sense of death denial. And it was a struggle for people. When they entered the nursing home, they would talk about, we don't talk about this. When, as they moved along the process and these cues were becoming more obvious, until we got to the point that corresponding with the look about them cues, in other words, you can see the shutting down of the bodily functions. They'd changed their approach and their attitudes to we don't shut the door. And they were making it available for these residents in nursing homes, their new family, to make sure that people came and said goodbye. I did the same study in an acute hospital. And instead of just talking to the nursing staff and direct care workers in that way, I included the whole team in that. So there's doctors, nurses, pharmacists, therapists, you know, physical therapists, etc. Even the ward receptionist and the porter that was coming in and out of the ward as well. So we asked them all, how do you know that somebody's dying on this unit? This is a unit that was for older people specifically. And what we found is, of course, if you ask more people, it becomes more complex, but hopefully a little more clearer. So what we have is three processes. The first process is the patient process. Whenever you go to hospital, whether you know you're dying or not, the purpose of going to hospital is to get fixed. And so there's always investigations and diagnosis going. So you go to hospital, and hopefully you start responding, and maybe you'll go home. But when people are starting to perhaps be in their last admission to hospital and going to die there, what we first find is that they don't respond to treatment, and people start asking questions. Then actually what I'll do is the next process. So the next line is actually the health professionals as a team or as individuals, how they respond to the patient's progress. So here's the patient responding, and we continue on with investigations and diagnosis. When the patient stops responding or is not responding so well, they start to ask questions. Should we escalate treatment, or should we wait and see what happens? And so we start off with active treatment, and it's very much recovery focused. Our aim is to get this person better. So that's why we're asking these questions. The patient's progress continues, and they're not dying, but they're not getting better either. And so we called that period of, in limbo almost, of being candidacy for dying. They're not quite dying, and then ultimately they move on to active dying. So the health professionals here were asking questions, and then there begins to be the process of actually diagnosing dying. Now, you might think that's an odd thing to do. It's not like an illness, is it? But actually, it's very important to do, to actually make the decision that this is what is happening with the patient, because without the right diagnosis, you don't have the right treatment. So ultimately, we hope that active dying is happening, dying is diagnosed, and we shift care. I want to come back to this treatment trajectory, because what we find happens is that active treatment, of course, is what happens when people first go to hospital. As we enter this not responding and into the candidacy for dying, we get a mixed, unpredictable care. People don't know quite what to do. They're not ready to move into comfort care, where comfort is the only goal of care. And so we have all sorts of people doing different things. Some people thinking we should be pulling back on treatment, on active recovery-focused treatment. Other people thinking that we should be keeping going. And so patients and families can get very confused. And sometimes it means that we don't make the decision and active treatment goes on to the very end. And the most disturbing part of that is that we end up with people who are having blood drawn on the day that they die, or have spent 2 hours with their head in a CAT scan instead of with their family. So we need to get better at doing this. So I think I've probably covered this. If we don't recognize that dying is imminent, we don't transition to good best care for dying people, which makes it harder for us to die well, which has the implications for survival in our family members. So my second proposition is that when physiological dying begins, healthcare should stop and dying care should take over. Healthcare is recovery focused and it aims to prolong life and function. Dying care is comfort focused and it aims to support the developmental transition. The trouble with providing healthcare to someone who's dying is that it does not prolong life, it prolongs the dying process. And I think many of us have probably realized this, but Asimov, one of my favorite authors, suggested that life is pleasant, death is peaceful. It's the transition that's troublesome. And a lot of our work in healthcare is about keeping us well and healthy for as long as possible. The period of deterioration that leads to death, we want to make as short as possible and with the least suffering. And when we keep providing healthcare when people are actually dying, we end up prolonging that dying process instead of keeping it short. So our solution, we must talk to each other. We've got to talk to our partners and our children, tell them what we need and what we want. We must try to stop being afraid of dying, or at least the dying process. None of us wants to die. Our drive for survival is very, very strong. But given that it is inevitable, we need to start stopping being frightened of this process. We need to at least stop being afraid of talking about it. As Erik Erikson, the developmental psychologist, said, healthy children will not fear life if their elders have integrity enough not to fear death. So what's next? Well, I'm going to continue this work with that older population, particularly those with dementia at the end of life, and taking the person-centered approach. And I am very pleased that the University of Buffalo is supporting this work with an institute where we are going to focus our work on that way. And if you'd like to look at the website, you can follow our work there. So thank you very much for listening.